Hi, welcome back to Pulamed. Today's sample notes will be on antiplatelet drugs. So let's proceed without any further ado. Let us start our notes with an introductory flowchart where there is platelet attaching to the subendothelial connective tissue, then releases thromboxane A2 as well as ADP. This causes recruitment and activation of platelet, GP2B/3A activation, then platelet aggregation. If there is one thing you should know of me, that is I never miss the opportunity to draw a diagram when there is one. So let us draw platelet with COX-1 and PDE3 in the cytoplasm and receptors outside. The receptors are going to be PAR1, P2Y12 and GP2B/3A receptors. These are the receptors for thrombin, ADP, von Willebrand factor and fibrinogen respectively. Let us dive into classification. We have two categories of drugs, one inhibiting platelet activation and recruitment, the other inhibiting platelet aggregation. So in the first category, we have COX-1 inhibitor, aspirin. We have PDE3 inhibitor, that is silostazole, as well as dipyridamole. Then we have PAR1 inhibitor, that is orapaxar. We have P2Y12 inhibitors, prasugrel, clopidogrel, ticagrelor, and cangrelor. We also have drugs that inhibit platelet aggregation, GP2B/3A inhibitor, apixaban. Coming to indications, antiplatelet drugs are used in coronary artery disease, ischemic cerebrovascular accident, transient ischemic attack, peripheral artery disease, thromboprophylaxis, carotid atherosclerosis, as well as venous sinus thrombosis. With respect to adverse events, usually the ones that we are worried of are bleeding. And for few drugs, we have thrombocytopenia and peptic ulcer disease can occur due to aspirin. And contraindications are active bleeding, and few other contraindications are there for certain drugs, which we'll be discussing in subsequent slides. Coming to aspirin, aspirin has its antiplatelet action for lifetime of platelet, that would be 7 to 10 days. And aspirin is an irreversible COX inhibitor. So it blocks thromboxane A2 synthesis and thereby prevents recruitment as well as activation of platelet. P2Y12 inhibitors, we have two categories, reversible and irreversible. Among reversible, we have ticagrelor and cangrelor, whereas irreversible would be clopidogrel, prasugrel, and ticlopidine. Clopidogrel is a prodrug. It is better than aspirin with respect to secondary prevention of stroke. It is usually a member of DAPT, which we use along with aspirin. Still, there is one problem with clopidogrel, that is CYP2C19 inhibitors like PPIs. They try to decrease the efficacy of clopidogrel. But among the PPIs, the better ones are rabeprazole and pantoprazole. They do not decrease the efficacy of clopidogrel like other PPIs. Still saying that in certain phenotypes of CYP2C19, we do not prefer clopidogrel and we try to use other antiplatelets. Prasugrel is more efficient than clopidogrel, yet it got bleeding risk more than clopidogrel. Hence, we do not use it unless in those polymorphisms where clopidogrel cannot be used. Despite saying this, prasugrel is not fit for those who are older than 75 years or those who got TIA or past history of CVA. Ticagrelor, just like prasugrel, is an alternative to clopidogrel. Bentracimab is a monoclonal antibody which can be used to reverse the antiplatelet effect of ticagrelor. Coming to cangrelor, it is a parenteral drug. Its onset is within minutes, and its offset is just 1 hour of discontinuation of drug. Much useful in peri-procedural prevention of MI. GP2B/3A inhibitor. Before going to that, GP2B/3A is an integrin, and its absence could result in a disease called Glanzmann's thrombasthenia. Now, GP2B/3A inhibitors, they are given parenterally and they have got small therapeutic index. Examples are apixaban, tirofiban, and eptifibatide. Eptifibatide is specially derived from rattlesnake venom. Now, before concluding the answer, one point on silastazole that is used in PAD more often. Do not forget flowcharts and diagrams. Subscribe, like, and share the video. Thank you.